Hey, good afternoon. Dr. Alan Christensen here with you. Welcome to Office Hours Live. So it's been a couple weeks. Good to be back with everyone here. Yeah, fun to. So Office Hours Live. If you've been before, welcome back. If you're new to this, here's what we're up to. I'll take a minute and talk about some of the big things that come up, some of the big topics I get asked about quite often. I'll mention a couple of those, and then I'll take a few live questions. So there were some questions sent in advance about this already, and some of the big ones have been about menopause. So at the opening, we'll talk a little bit about menopause, but other than that, we'll talk about whatever's top of mind. So good to see you all. I'm with you guys on YouTube Live. I'm on Instagram Live and Facebook Live, and happy platforms. So yeah, we'll talk about menopause a bit. Some of you also asked about how the training has been going, how the racing and training have been. So yeah, I'm a competitive athlete, and I did my first ever triathlon this last Saturday. It was a fun experience. I've done a lot of running and biking over the years, pretty familiar with those. The swimming is pretty new. I've always been able to swim, but as far as covering distances, that's brand new, like last few months. So the event was great. I was able to look at where I swam on a map compared to where I was supposed to swim on the course. And I did a lot more distance than I had to, which was pretty silly. So yeah, it ended up being like 500 more yards than the course was meant to be. And I still got third in my age group, so that was cool for my first one. I was pretty happy about that. But it was a fun time, and I'll do more of these. So I'm seeing Joanne, I'm seeing Jean, I'm seeing a lot of familiar names here. Good to be with you guys. Thank you. Yeah, good to be caught up and good to be back here. I've got some travel next week. The week after that, I should be back mostly in a regular rhythm, and then a fair amount of speaking for some training some doctors, but those things shouldn't interfere with it. So welcome. Many are just jumping on. So let's take a minute and talk about menopause. This has been a big topic. I'm seeing some questions come up as well. I'm seeing some pop up about thyroid antibodies and what they mean about Hashimoto's. We'll talk about that. But to popular request, let me talk a little bit about menopause for starters. So the question I got was what to do about menopause and fatigue, weight gain, muscle loss, sleep quality. And I want to cover a couple of those that tie. I'm seeing more good questions come in about iron. Thank you for that. This is coming on Instagram. We'll talk about iron today for sure. But yeah, we'll kick off with menopause. Now, Facebook, you can see some images that I share. Instagram, they won't be visible, but I'll explain it pretty well. I'm seeing congratulations. Yeah, thank you for that. It was a really cool event. I met a neat guy who was in the age group above mine, and he, took me under his wing a little bit and showed me the ropes, so to speak. But it was a lot of fun. It was a great community, and I'll do more of those. I'm still not sure, how much I'll push the endurance thing, because I can go a long way. I'm better at longer events, but then I injure. So I'm still kind of debating if I'm going to stick to. This one was an Olympic triathlon. For those that know about that, so it was a 1 mile swim, a 20-mile bike ride, and a 6-mile run. So the bike are very short for me, very easy. The swim is no problem. But I'm just planning if I'm going to go further with those or stick with marathons or what. So we'll see. But it was fun, and I did well. I could do so much better if I just swam in a straighter line. So my new strategy is point the right direction. So yeah, back to menopause. So I'm going to focus in on the sleep and the weight part, because there's a lot of facets to that, and they're super, super important things to sort out. So I'm going to pop an image up that'll be visible on the Facebook and the YouTube Live. So menopause, the old idea was that it was a drop in estrogen, and that's where everything happened. The emerging idea is change in estrogen receptors, and it's a change in how estrogen is absorbed. I'm seeing comments pop up about this. Talking about menopause for sure. We'll talk about weight, and that'll be the big focus. Now, weight gain and energy, this question prompted that. Let me lead with how these things are tied together. So weight gain and then weight loss is energy being stored in the body, but not being released. Right now I'm talking to you guys, but I'm not eating, right? So I'm releasing energy. I've stored some in my liver, in my muscle tissue, plenty of fat tissue, and it's being released as I need it, right? So if that cannot be released, then you're tired. Your body can't make fuel. You can't access fuel effectively. And that means weight stores but doesn't come off. So you have fatigue and weight gain. They're almost always two sides of the same coin. So please be aware of that. And where that's occurring, the main organ that's managing storage of energy and storage of fuel, let's see if one can answer that. I'm going to watch out for some comments. So a lot of folks are just jumping on. We're talking a bit about menopause and the connections between menopause and easy weight gain. Weight. So where's the organ in which fuel is stored and cannot get released? What's the connection that way? Any guesses? I'll keep my eyes open for that. Oh, I'm seeing a comment on Facebook about that. Aesthetic Love is guessing liver. I'll see for any others. As I'm watching for these guesses are coming up, a really easy one just showed up. Someone's asking about office phone number. Sure, office phone number for easy iron. Yeah, the office phone number is 480-657-0003, and they can help you with that. This is a Monday, and it's 1 o'clock in the Arizona time zone, so they're open. So 480-657-0003. Yeah, can help assist with that. So I'm seeing more comments. Exhausted, can't sleep, can't lose weight. They go together. Yeah, the fatigue and the weight, being stuck, those things go together. And I saw a lot of folks guess liver. You guys are spot on right. So the liver is managing thousands and thousands of things that need to be in our bloodstream at the right amount. And ultimately, all this stuff comes from our diet. You know, our vitamins, minerals, amino acids, it all comes from food. But we're not constantly eating food. It's not coming in right as we're needing it. So we store things, we make some things, and we put that, we need it. Well, we're also storing our energy. So now the liver also has a big job to play in regulating estrogen and how estrogen is broken down. This chart is just showing how estrogen receptors act on different parts of the body. And as a generalization, there's one group of receptors that does things that are largely desirable. It helps estrogen thicken the skin or improve mental function or grow healthy bones. There's other receptors that do less desirable things. They trigger hot flashes. They cause breast hypertrophy and raise the risk of breast cancer. They cause uterine lining enlargement and the risk for bleeding or endometrial cancers. So we've got the alpha receptors and the beta receptors. And conveniently, they're kind of like A is good and B is bad. Now, it's not that simple, but for our purposes, we can think of it like that. So what's happening in the context of menopause is that there's too much alpha activity and too little beta activity. And how is that relevant to health and weight otherwise? Well, like a lot of you guessed, the liver is the center of all of this. And what's happening is that menopause is a trigger for fatty liver syndrome. There was a study talking about this, and it showed that all the changes in menopause make fatty liver a more likely problem. The changes in type of estradiol, the changes in androgens, these things all make it to where the liver can't use the way it does normally. And that's true for fat. It's also true from fat being broken down in the body. When the liver doesn't use fat as well, it changes how it can detoxify things. And that changes what kind of estrogen the liver makes. So in a roundabout way, the changes in estrogen change the liver, and they make it to where it becomes a vicious cycle. So as all this shifts, the liver gets better at storing and less good at breaking stuff down. And then we get stuck in this mode of gaining weight easily and not losing weight easily or effectively. So I'm just watching. Yeah, a lot of folks were guessing liver. Good guess on that, you guys. And Kelly's asking a couple things. Do you have physicians I can see that are trained virtually? Kelly, we do. Our doctors do work with people virtually in Arizona, California, Oregon, Washington, Montana, and Idaho. So yeah, in those 6 states, we do work with people virtually. And also, if I'm a fan of hormone replacement, it's got a place. There's a place for hormone replacement, and I'll come back to that. There's different sources of estrogen. There's what the ovaries make, the adrenals make, what comes in from the diet, as in phytoestrogens, and then HRT. And we'll talk about how all those things interplay. So good question, and stay tuned. We'll come back to more of that. So we think about fatty liver being the connection between menopause and weight gain. It all comes down to liver function. So how do you know if it's a concern for you? Well, the easiest way to first think about that is height to waist ratio. And this graph shows that. You can just plug in inches of circumference around the body weight. That's in this vertical scale, this X scale, and then height in inches on the horizontal scale, on the Y scale here. And it's really specific to the belly button. So to get a good reading, go with a tape measure around your belly button first thing in the morning, after you've had a bowel movement, and just relax. And then also just measure height. Your height doesn't change as much, so that one you probably know, but plug those in together and you'll see where you are on this range. For easy math, the relationship is somewhere around 0.5. So you want your belly button circumference to be 0.5 your height, or a little smaller, or a little less than that. So the closer it is to 0.5 or above, the more this fatty liver thing gets to be a concern. I'm seeing a lot of good questions and comments, you guys. I'm totally aware of these too. If TSH is high, thyroid disturbs the brain. Yeah, I'll come back to that one. Good one. And what's happening with fatty liver is that triglycerides are building up. The liver stores glycogen as a stored form of carbohydrate, and it stores triglycerides as a stored form of fat. Now, glycogen only goes in a few places. Fat can go anywhere, and you can add on a room for fat. You can expand where it goes and jam it, excuse me, inside cells or between cells. So yeah, fat goes wherever. Now, this is a progression of more and more fat. The number's about 5%, and that's not the same as body fat, that's liver fat. And there's no way we can really measure that practically. But once we get above that, there's a cycle of damage. So most people that struggle with their weight are somewhere getting close to that. They're not in this continuum to where it's going to be fatal, but for a lot of people, it does progress. And this becomes a whole separate thing that can shorten their lifespan as well as contribute to these symptoms earlier along. But it's just extra triglycerides. And the problem is that there's poor sleep quality and other factors that make it to where the liver's not making glycogen. So glycogen in the liver is what burns the body fat. And you need some good carbs for glycogen, and you need deep quality restorative sleep. So a few more notes about these, and I'll talk more openly about it. The liver then starts to leak. So there's so much stuff in the liver that it's leaking out these triglycerides. And that's when insulin resistance sets up. So insulin resistance is not a problem from carbohydrate, it's a problem from fuel overload. The body has nowhere to store fuel. So it's resisting the signal to pull fuel in. Because there's no more place for it to go. So the body ignores that signal on purpose. It's not a mistake. And the cool thing, though, is that this is really reversible stuff. The liver is the most resilient, regenerative, solid organ that we have. You know, in 28 days, it can completely regenerate and repair itself. So this is the main solution for this part of it is really the metabolism reset. And we commonly can see 2 to 3 inches of waist loss in the first phase of that, the first week or the first several weeks. And this affects how the liver is also managing other hormones, including estrogen. So I'll talk about other factors here. So the change that occurs with menopause to postmenopause is that the ovaries are not making as much estrogen. The adrenals are now making more of it. And this also brings in the relevance of adrenal health. And I'll watch for questions about that. We'll talk about those as well. But the adrenals and the adipose make more of the estrogen after postmenopause. So the other sources we have are hormone replacement, phytoestrogens, and then a lot of things that are overtly synthetic and problematic. That's going to be the contraceptives, and then the estrogen-like xenoestrogens are called, or the chemicals that act like estrogen. So pesticide residues or plastic residues, these sorts of things. Now, the relevance is that the healthier your adrenals are, and the more your body has fat tissue where it should be and not where it shouldn't be in the liver, the easier this goes. And for helping it, Also, then the less synthetic estrogens there are, the better. But as far as helpers go, phytoestrogens and hormone replacement can be options. They are things that can benefit with this transition. And as a generalization, phytoestrogens and hormone replacement, their efficacy is pretty close. There's a difference in how phytoestrogens are activated. And some people, per their genes, per their microbiome, they activate them better than others. And there's also differences in how hormone replacement is metabolized as well. So either of those can work for about 80% of people, not the same 80%, but they both can have some good considerations. So I'll make a few more comments about that, but I want to just briefly look and just catch up with some of the questions that have come in. Need to do another reset. Someone just said, hey, cruise on over to Metabolism Reset Challenge. Just Google that on Facebook. We're about to kick off a really big challenge right now. If you've not done one before, these are free and they're on our Facebook page. All the data is free. You can learn about how to do it. You can get some recipes and some guidance. We do have a detailed 28-day plan, but we've got a free 7-day challenge that'll totally get you started. So if you go to Facebook and just plug in Metabolism Reset Challenge, you'll find it. And we're just about to launch one. In fact, I'm going to go over there shortly and just welcome the new people into the group. So if you're due for a challenge, this is a perfect time for that. So yeah, good question. So asking about hormone replacement, someone just did, and mention that quickly. It's a safe option, and the doctors at Integrative Health do offer that. There's different hormones that are used. Of course, we've got estrogen, progesterone, and testosterone. There's different types of them, different delivery forms. And there are some contraindications, those that have been prone to coagulation, those that have had hormonally sensitive cancers. But barring that, they can be safe options and they can make a big difference. Many can do well on general lifestyle change also. I do see many that can manage hot flashes and hormonal symptoms pretty well just by diet and lifestyle change. Now, the first step is really the metabolism reset. And that's a matter of shedding that toxic fat in the liver that's disrupting the breakdown of estrogen. Because it's not as much about how much estrogen is there as it is about how the estrogen is processed. You know, what types of subtypes are being formed. And the body can change that very quickly. The next consideration really then are the phytoestrogens or the phytonutrients. Some of the big food sources of those, soy, flax, oats, those are the top three. We'll also see quite a bit of relevance in cruciferous vegetables, so cabbage, broccoli, and all of those. But all of these are compounds that they're not estrogen per se, but they do good stuff to the receptors. Specifically, they plug up the bad receptors that you don't want stimulated, and they clean up the good receptors so they can be more easily stimulated. So the same estrogen load can do a better job stopping hot flashes, helping skin growth, help bones be strong, while it blocks estrogen in the breasts and in the endometrial lining. So that's what phytoestrogens do. They help estrogen in some places and they block it in other places. And they're called selective estrogen response modifiers, or SERM for short. So pretty cool thing, but they're quite useful. And then just a couple of final comments. Many of the menopausal symptoms are greatly exacerbated by caffeine and alcohol, and that's because of their effects upon the liver and upon estrogen metabolism. But if you are struggling with any of those symptoms, yeah, do the metabolism reset. That gives you a break for 28 days from caffeine and alcohol anyway. Consider phytoestrogens. Soy, flax, oats are the real big three. Cruciferous are good as well. And then also think about HRT if need be for persistent symptoms. I just finished up a cookbook. We're in the process of getting it all photographed and published and put all together. So that'll be coming out early this coming year. And one of the sections for that is about hot flashes, about recipes for hot flashes. So those foods and a couple more. So stay tuned. I'm really excited about that. Okay. So let me grab a few more other detailed comments that have come in. A whole bunch here. Hey, Kelly, you're here. I'm taking a peek at ones that are related to the topic that I've mentioned for starters, and then I'll branch out and get ones on other topics. Let me adjust one camera real quick here. There we go. Okay. So one about, I see a couple about iron. And here was one about iron bisglycinate. After taking an iron supplement in the form of iron bisglycinate, hair becomes drier and brittle. Hair loss gets worse than before. So great question. So one form of iron wouldn't worsen hair loss per se. Now, it's totally true that low iron can be a big contributor to hair loss, and it can delay hair regrowth. And this is even more of a problem for those who are prone towards thyroid disease. We know that iron is a big part of thyroid peroxidase and many other enzymes that regulate thyroid hormones. We also know that the hair follicles are sensitive to small changes in iron status. So someone else mentioned this, Kelly did, my hair is dry and falling out, it's awful. This can be a big deal, and many things can be factors, but honestly, iron is one of the biggest single ones. So if you are a woman who is menstruating or was rather recently menstruating, I almost assume this is a culprit. A big thing to know is that iron can be a factor even if it's normal. I'd encourage anyone who wants to go further on this, just Google Alan Christensen and iron. I've got a very detailed article that talks about this, and another one about hair loss and how they connect. But it takes more of a lack of iron to cause hair loss than it does to prevent hair regrowth. So you've got to be pretty low to where it makes you lose hair, but you've got to get all the way back up again before hair comes back, if that makes sense. And some types of iron work better than others. I'm a big fan now of Easy Iron. That's my personal favorite. I'll make sure that there's links available, but if you go to shop, I'll just put this link up here. This will show up readily on the Facebook and YouTube chat. I can go in that chat real time. So that's where you can find Easy Iron. This is by far my favorite iron formulation. This one is ferrous fumarate, which is a kind of iron we find in plants, especially mushrooms. It's also a black pepper extract called piperine, and that's been proven to make iron twice as absorbable. It's already bound with vitamin C. So when you take iron and vitamin C, it's not the same as when they're bound up already in the capsule. And then this also has citric acid. So no other products I've seen have done this before, but there are published studies saying that citric acid can radically improve iron absorption. So this is a one a day for most people. You often only need one capsule daily to reverse low iron levels. So yeah, Tibby, if you've been struggling with iron, consider Easy Iron as an option over iron bisglycinate. Iron bisglycinate is the next best option, but Easy can work better for most people. But iron bisglycinate, it wouldn't worsen hair loss per se, but it may not be enough to correct or reverse the hair loss. So that's a more likely scenario. And Kelly, just for some feedback, if you do identify the culprit and you do treat the culprit, hair loss usually stops within a matter of weeks, maybe a month or so, but it doesn't take all that long for it to stop when you're on the right track. Now, regrowth is slower. Follicles go through cycles of activity and inactivity on 3 to 6 month cycles. So the upshot of that is it might be 6, 9, 12 months to see a real big change in hair regrowth. I'll often hear people say 3 to 6 months into something that they're seeing some little downy hair fill in where it was missing. So that's common, but it may take a little longer. But when a cause is found, it's almost always possible. And yeah, low iron is by far the most common. The next most common for women is high androgens. I talk about that in those articles as well. Then we think about cortisol. But yeah, I did mention all those and how to know which it might be and what to do about all of those. Kelly, another one, just to address this, others might have the same question. You're the best, Dr. C. Thank you. So glad I found your MRD. I wish you were seeing patients. Yeah, Kelly, so I did do clinical care for a long time. Now, there's two options you all have for working with me and my team. The team does the prescription side, so they'll manage the thyroid meds, the hormones, they'll take care of all that medical side of it. I do act as a consultant, so those got booked up pretty quickly, but I do open up times in which I will see people as a consulting doctor. So I'm not acting as a prescriber just because my schedule doesn't allow me to maintain regular care, and I'm just not available regular enough as a doctor needs to be for someone who is under their precise care. But I can do second opinion consults. And I'll put that link up here for you guys. That's thyroidopinion.com. Right, yep, okay. I'll drop that link in. So Thyroid Opinion, just common spelling for both. And I think I've got a few of those for the fall that are still available. So if you do want to just talk directly, Kelly, yeah, I can totally consult on your case. And the way those work is that you get a chance to send in all of your labs, all of your questions. I actually ask quite a few to prompt and to understand, where you are and what your goals and what your needs are and what you've tried and what worked and what didn't work and what all the diagnosis you received and what all of your findings are. You can upload those things. And then I review that. Lost my voice on the race. I'm sorry about that. All the huffing and puffing. And the funny thing is, we always try to drink water when our voice is hoarse, right? It doesn't even go there. It goes down the esophagus, not the trachea. But if it moistens a little bit, it might help. So anyway, yeah, I can totally consult on the case. I'll read all of your stuff beforehand. And we would speak just like this, but just one-on-one in person. And as we're speaking, I start taking notes. And when we're all done, I write up a real detailed plan of recommendations and suggestions for you. And, put links in there as is appropriate and follow-up steps and referrals, whatever else you might need. And we get all this sent off. And if you're working with a different doctor in your area, you can just share that with him or her and get that input. If you're working with one of our doctors, then that's easy because I just talk to them directly. I do that all the time anyway, but that's totally an option. And I really enjoy those. It's fun to still work one-on-one and give direct input on things. So yeah, here's a great one. I'm going to do my best, you guys, but I got to admit, I'm failing. Yeah. Is there a way to do a hybrid ARD and MRD? Have high cortisol with liver issues, which would you do first? I think not sleeping is due to high cortisol at night. Yeah, Kelly, there is. And really the MRD, if you're following those guidelines, you're getting a lot of the benefits for the ARD as far as the dietary benefits. Now, those who aren't aware of these buzzwords, the ARD is the Adrenal Reset diet, MRD is Metabolism Reset. So Kelly, the Adrenal Reset, if you've got the book, take a look at the chapter that's per your level. The book also has a quiz, and do a quiz if you've not done for a little bit. Do the quiz in the book. That'll direct you to one of the 4 levels, the thriving or stressed or wired or tired or crashed. Each of those levels has a chapter about it. There's some general dietary guidelines in those, and then also a lot of detailed lifestyle steps, including how to time light, how to do different breathing exercises, adaptogens you might consider. So the short version is do the MRD 28-day diet program and do the lifestyle steps per your level for the ARD. And you can totally get a 2-for-1. And then the other thought is look at both the maintenance ideas in the MRD as well as the longer-term dietary suggestions in the ARD. Now, when you're following the ARD, your levels often change quickly. You're not staying at the same place. You'll often move up in a matter of just a few months. So even after you go through the reset once, you should repeat your adrenal quiz. You may be at a better level just that soon, but you can definitely get the benefit of both of those. And the cortisol can be a big deal. Here's one from Lori, and I'm going to grab a few more over here on Instagram that were related to specific thyroid levels. But Lori's saying, I've heard you say people way over 65 may not tolerate liothyronine. How much over age 65? Thank you. So Lori, yeah, what I would have meant to have said is that there are those over 65 that can be at risk from cardiac effects from too much liothyronine. So it's not that they always have symptoms, because they may not, but it could give them risk for rhythm disturbances, so atrial fibrillation or overt palpitations. Yeah, there are those that don't tolerate it, and they're aware of that at any age. And that's not the majority of people, but I would just estimate that it's around 5% or so, that any age, if they take natural thyroid or any pure T3, it feels like too much, even if it just shouldn't be, even if it doesn't give them excessive levels. So that does happen. And in terms of the risks, though, that 65 is the place where that starts to be thought about. So if someone is over 65 and they only do well with liothyronine, or I'm sorry, with some T3 in their therapy, I don't suggest liothyronine as a monotherapy. There are those that do, and I understand a lot of the rationale, but it's just not how the body works. You know, our body makes mostly T4 and some T3. And by and large, if you're going to do something radically different than what the body would do by itself, you need to have strong evidence that it's okay. And we don't really have that evidence. There's a lot of reason to think why it may not be okay. So I think T3 is great for many people as part of therapy, but I don't suggest it as the sole therapy. And yeah, if someone does have no real risks, they only do well on natural thyroid, it's totally reasonable. But if someone is well over 65, they have cardiovascular risks, they do fine on T4, I would certainly leave the T3 out for them. So yeah. You know, and Lori, just a follow-up comment for you. If you're on T3 and T4 compounded and you're getting palpitations, the first thought is it too much? And the first change that shows that it is your TSH creeps down. In that case, it's very common to have cardiac side effects. Lori, I don't know if you heard me talk before, but compounded meds, I like the idea, but I wish there was quality control. I wish there was some way that they were tested to know how much was in each batch. There's not. And there's a lot of cases that get published in which they're way out of the range, like hundreds of times out of the range. So my confidence in them being within a few percent of target is pretty low. I've had a lot of negative experiences with patients who were on compounded medication. And I really do recommend against it if at all possible. And I'm not alone. There's published studies each year about case reports of those who were harmed by compounded thyroid medication. So the medicine might not be what you expect, but if your TSH is low, you're getting too much, and that commonly would cause palpitations. And that does make it more of a risk. And I'm going to grab a few more on Instagram here. I'll come back over. I'm at the lake home in Minnesota, so the setup is a little different. I can't see all my screens quite as well as I would otherwise. I'm actually going to move one completely over. Okay, so forgive me for looking back and forth a little bit here, but I can see better this way. I can see the Instagram comments better. All right, now they're well in front of me. Everything balanced properly. There we go, something like that. And here was one. Someone was asking, okay, Cindy Purple, Cytomel 25, TSH very low. How much Synthroid do I need? So Cindy Purple, TSH is 0.2. So yeah, there's too much overall thyroid hormone in that case. And if you're on no T4, I'll answer it as if you're on no T4. So if you're on 25 micrograms of Cytomel, that's T3, it's about 4 times the potency of T4. So it's about 100 micrograms equivalency if it were only T4. I just mentioned a moment ago from another question that I'm a fan of using those two hormones together rather than just T3. Just T4 works for some. The combo works great for many. I don't recommend just T3 by itself like you are. When they're synthetic and isolated, often I only see people need small amounts of T3. When they're in the form of natural desiccated thyroid, they come in a 4-to-1 ratio. And the way they're bound up in proteins in that case, it works a little differently than when they're isolated synthetics. So the 4-to-1 I think works great for natural thyroid. When they're synthetic, I often start at ratios of like even 10-to-1. So if what you're taking equals about 100 micrograms of T4, one consideration could be the smallest potency of T3, which is 5. So 5 times 4 is 20. That would leave a remainder of 80 micrograms of T4. Now, you're getting too much, so a doctor could do, say, roughly 75 of T4, 5 T3. That could be a starting place. Or one could do roughly 1 grain of natural thyroid. That's about the same potency as what you're on too. But again, you're getting too much. So half a grain, 3/4 of a grain. Those are all the ballparks that one would think about. But more and more, Cindy Purple, when someone's taking a dose like that, that's not super high, I wonder if they even need any. I see so often that people need just less or none and doing fine on that. So that's really common. Okay, lots of folks jumping on, just making sure I'm current with some of the questions. There were a few more. I had seen another one about iron also. And, oh, this is one I'd seen before. If TSH is high, could that mean thyroid receptors in the brain aren't being fed properly, leading to poor cognitive function and brain fog? A high TSH can correlate with brain fog symptoms for sure. Now, here's a really important distinction, you guys, and this can be a tricky one. A lot of doctors don't parse this properly. So if a high TSH causes a symptom, it's logical to think that therefore lowering the TSH with medicine could help that symptom. But we're seeing more data saying that those are separate questions. Yeah, it could be a cause, but lowering the TSH synthetically may not be a solution and may not help that very symptom. But if one can do diet or lifestyle changes that lower it, that's different. That's totally different than lowering it with medication. So the data is getting more clear that the thyroid that you make is not the same as the thyroid you take. Even natural desiccated thyroid, as much as possible, if your body can make it, that's the best thing and that produces the best outcomes. Let me grab one last one. Voices come back in for a little bit, but I just saw one that mentioned parathyroid disease. I'll certainly address that. Robin's saying, I have parathyroid. Is that the same thing? So Robin, I'm guessing you mean parathyroid disease. If you want to talk more about that, like what your diagnosis was or what your symptoms were, I'm happy to address that. Parathyroid and thyroid, the names overlap, right? So para means next to. And the parathyroid glands, there's normally 4. They're normally bordering the thyroid. There's normally 2 on each side of the thyroid. They're neighbors, but they do different jobs. The parathyroids control calcium metabolism. And it's not as common that they're off as it is that the thyroid is off, but it does happen. And those prone to thyroid disease are more apt to get parathyroid disease. And it's a big deal, and it really does demand treatment. So happy to address that more specifically. And one more one here. This is also from YouTube. Best plan to reverse high antibodies. TSH is normal. I don't take any thyroid medication. Yeah, Kapurl, great question. I dropped a link up a few moments ago, and I'll put a more specific one. This is about a blend. There's good data about micronutrients lowering thyroid antibodies. And I went through all the literature on that and just made this blend. All the high quality placebo-controlled double-blind human studies that showed safety and real-world outcomes. And that's what this blend represents. So that's the easiest first step. The other consideration is the thyroid reset diet. And that shows how the exact window of iodine can help to lower those antibodies and cut the risk of disease progression. And the overall takeaway point I'd love you to have is that thyroid antibodies often do come down, but they've shown that even if they don't lower, those steps still cut the risk for disease reversal. And the name of the blend, I'll put this up, is Antibody Support. I just dropped that in the chat comments there. And that's the blend made to lower thyroid antibodies. So really easy, 2 of those once a day, and works best with the thyroid reset diet and works best in an overall low iodine state. So yeah, do that. Do the daily reset bundle, which is on that same page. That's your baseline micronutrients. And the 2 of those just cover the basis for lowering the thyroid antibodies. Okay. I'm seeing some thanks. You're welcome, you guys. Good to see everyone. So up here back in northern Minnesota, it's a beautiful day out. The weather kind of goes back and forth, but here's the lake right behind me. And yeah, this is where I'm from. And I'll be back and forth to Arizona. I love Arizona. I love seeing my team and hanging out with everyone, but this is home. So related questions, I'll grab one more. Should antibodies be at 0? Farm meats table. Good question. Well, should, if it was like flipping a switch, why not, But if they're not at 0, is that catastrophic? It's not. The risk of disease progression when antibodies are in the 3 digits, like say in the 50s or low hundreds, is not that different from when they are at 0. So not a huge difference. I'm seeing comments about the view. Yeah, thank you guys for that. Let me share the camera on the other setup too. I think it'll come clear if yeah, there we go. There's the lake. We've got a couple boats set up. Got a canoe and a kayak and a stand-up paddle board. So happy to be up here and happy to be around family too. You know, it's, I don't know, last fall, those who were around a lot, you guys know that I had West Nile virus. I was pretty sick. It was touch and go. And there's something I read about called post-traumatic growth, which is, you hear about this from cancer survivors. You know, they have something happen and their perspectives and their values change. And after all that happened, I don't know, I don't think I've ever been too terribly off course, but my parents are still, I was adopted, so I've got 4 parents, and my birth mom has passed away, but my adoptive parents, they're pushing 90, they're in nursing homes, and there's not a lot, they don't have a lot of time left, but I just wanted to be there for them. And that was like the most important thing to me. So Kieran and I wanted to go somewhere cooler to give our son some space in Arizona, let him have his school experience. But I wanted to be by my parents and to be around them and, you know, seeing family. And it's so important. I mean, just take the time that you guys can to be with your loved ones. And that's more important than anything else. Just yesterday, just hanging out with mom and dad, and I just took them to church and sat with them, and bringing dad to visit his brother who's sick. And that's what matters in life. You know, and on the relevance of health, that's what brings us health too, is our time with loved ones, our social connections. It's critical stuff. So yeah, good to see you guys. Next week, I'll be with my son in Yosemite for a little bit, but the week after I'll be back and I'll pick up the menopause discussion further. In the meantime, keep sending in your questions. I read all of them and they inspire what we talk about, what I write, and what comes out next. So yeah, take great care, and we'll talk in really soon. Bye-bye.